comprehensive and you've covered all the major steps. And now our next speaker for the day is Dr. Jyothi Anup. She is the CEO and Medical Director of Eye Vision Hospitals, Parvatani at Thrissur. Over to you, Dr. Jyothi.
Thank you, Marin. About Dr. Preethi's presentation, SICs also should be done in step by step. The first 5 cases, this is what we do. The first 5 cases, rectus, peritomy, cautery and scleral groove is done. Subsequent next cases, till scleral dissection is done. The next 5 cases, capsulotomy and hydro procedures and nucleus prolapse. And finally, the nucleus delivery, cortex aspiration and IOL implantation. So by the end of 20 cases, the trainee will be able to do the case independently but with supervision. The training surgeon has to be physically present at least in the same OT or in the next OT, so that whenever there is a need for help, they should come and help. They have to bypass that step. So having learned to do a good SICS, next step is to upgrade to phaco. So my topic for today is stepping stone to phaco. Why do we need to upgrade? Because the results of phacoemulsification are definitely better than SICS, and very small incisions are possible. We can do under topical anesthesia, and you have the confidence that you are offering the latest technology to your patient. And before starting phaco in your clinic, you have to make some plans and changes. The most important plan is to invest on a phaco machine and a microscope with XY coupling and motorized foot pedal. And besides your own training, you need to train your OT staff also to handle the machine. And these are the technical differences. When you shift from SICS to phaco, there are few steps which are common to both technique, and there are few steps which are totally different. I would like to stress that in SICS, the rexis should be at least 6 mm, and it can vary depending on the hardness of the cataract, whereas in phaco it is 5 to 5.5 mm, and all the maneuvers we have to do it within the capsule. And your training in phaco starts right from when you are doing your SICS. As I told, few steps like tunnel construction, rexis and hydrodissection are common to both, and you have to master all these steps while doing your SICS. And a good hydrodissection is mandatory for phaco, as you need to rotate your nucleus, and no compromise on rexis is allowed, or it is not forgiving. And you can practice your bimanual IA before even starting your phaco, as you can see in this video. And I would recommend this book for all aspiring phaco surgeons to read. And you should have some idea about your phaco machine and the various modes used. In pulse mode, that is the commonly used mode, there is a burst and a rest phase, and this comprises of a duty cycle. And you can set your duty cycle in the machine. Next, another one is a hyperpulse mode. It is better to go for a machine with hyperpulse mode, where the pulses are so short that hardly any heat is produced. And before starting scrubbing, you should go into the OT, adjust your chair, microscope and foot pedals. I am telling you, sitting on a chair with wheels with all 4 your limbs are engaged and doing a tough surgery is no fun. You have to have some time to do it. And after the optimal rexis, this point I wanted to stress, you have to decompress your chamber slightly to do a good hydrodissection. Observe for the fluid wave. And if your hydrodissection is not good, you won't be able to rotate. You can rotate the nucleus 2-3 times before even starting. And this is the technique for a beginner phaco surgeon, divide and conquer, where you have to sculpt and make 2 trenches. You have to go deep, widen the trench as you go deep. You should not push the nucleus while trenching, and make 2 trenches, one perpendicular to each other, to make a cruciate groove. Till this you are doing in a phaco machine setting, one with a less vacuum. And to crack, you have to keep your probe at the base of the trench so that you get a very good crack. And for emulsifying the nucleus, You have to increase your vacuum. There is a different setting in the phaco machine for that. And for a beginner phaco surgeon, it is better to inject visco before emulsifying each piece, as you may invariably you will be liberating some phaco energy, and that can spoil your cornea. So it is better to inject liberal viscoelastic, especially before emulsifying the last piece. And once you are comfortable with your divide and conquer, you have to shift to the chopping technique. Here I am demonstrating a horizontal chop where you have to go till the equator and chop. So it is better like you are going nearer the sonule. Some compromise on the sonules are expected, so be ready for that. And in between, when you shift from divide and conquer, you can do a stop and chop. All those things Dr. Marin will be showing you in videos in detail. And after the nuclear emulsification, the trainee should go back to their familiar steps, like you can use a Simcoe in cortex aspiration. So if your hydrodissection is very good, your cortex aspiration is going to be very smooth. You will hardly have any cortex to aspirate. What point I wanted to stress is that the novice surgeon should take only the stress of nuclear emulsification. Rest steps they can do whatever steps they are familiar with. As phaco is less forgiving and every step is important and need to be perfect in phaco. As you can see here, the tunnel was slightly posterior and there is conjunctival ballooning, and this can go up to 360 degree and make lot of stress to a beginning surgeon. And if your tunnel is slightly longer, that will create corneal folds and it will be impossible for you to continue the phaco. And in spite of doing everything perfect, still you can end up in some unexpected problems in phaco. Till the probe is inside your eye, you have to be very careful and vigilant. As you can see, a very small bit of nucleus which should have removed with an irrigation aspiration probe, and a PCR is made. Don't be panic, and you shouldn't remove the phaco probe. As soon as you create a rent, you should inject visco through the side port, and then only you should remove. And always keep your phaco probe in the center of the pupillary area and do maneuvers. If you go in the periphery, you may either catch your iris or the capsular bag, as you can see here. Phaco is less forgiving. You have to be very vigilant and careful. Finally, I want you to drive home the point that how much you are confident you are in doing your phaco, you may still have to convert to SICS. As this is a case of post-vitrectomized eye, you can see the silicone oil in the chamber. So, in post-vitrectomized eye, some posterior capsular compromise is expected. So, anticipating that and planning for a scleral tunnel. So, in case if you have to convert, you can convert it with ease and comfort. And the rhexis was uneventful. And whenever you see a clear area in the phaco, you should always suspect a PCR. And this is not vitreous, this is silicone oil which is coming up. There was a large PC dehiscence. The conversion was already, like, it was very smooth. Or in the other way, when you experience any unexpected problem in phaco, as you can see a large rhexis tear known as Argentinian flag sign, don't hesitate to convert. Here it was a clear corneal temporal tunnel. Now going for a superior tunnel with a frown incision, and the surgery is completed. So while creating the tunnel, there will be a side port there. You have to go slightly deeper in that area. And go for a 3-piece lens whenever there is a rexis compromise, as you have to implant in the sulcus, and a -1 IOL power is adjusted so that still you may get emetropia. So this is the difference between a planned conversion and an unplanned one. You may still have to suture. Don't hesitate to suture. So this is where the initial steps, the good suture practice is also needed for a sutureless surgeon. Thank you.